diabetes like many other Malaysians. She's under follow-up with a private GP. She's on amlodipine 10, atenolol 50 milligrams, and metformin 1 grams a day. This was a blood profile and a urine profile, along with a blood pressure in February 2018. Her EGFR and the MDRD formula was slightly low, but nothing untoward for her age. She had macroalbuminuria with 2 plus of urine protein. HbA1c was well controlled, but her blood pressure wasn't. So when she came back to her GP in October 2018, her creatinine had gone up slightly with a corresponding drop in EGFR, but the GP was rightly more concerned with the proteinuria, which was rising. So what the GP did was to change the amlodipine to a single pill combination of amlodipine valsartan. So she then comes back 3 months later to remind you she's now currently on glucophage, amlodipine valsartan combination, and the atenolol medication. At this point, her blood test shows that her creatinine had risen quite rapidly, with more than 30% rise in creatinine, with a significant drop in EGFR. Her proteinuria had returned to her baseline, but the potassium had climbed up to 5.9. Her blood pressure was still suboptimally controlled. So the GP was quite concerned, told her to come back a month later, and the creatinine continued to rise, and the potassium as well. So she was referred to myself, and what I did was I stopped the single pill combination of amlodipine valsartan and also the atenolol. I started her on indapamide amlodipine combination medication. So the rationale for me stopping the amlodipine valsartan combination was, number one, hyperkalemia. Now, all ACE inhibitors and ARBs blocks the renin-angiotensin system and therefore reduces the floating aldosterone levels, which then causes reduced secretion of potassium into the collecting ducts. Secondly, most likely she has a significant renovascular disease, because there was a more than 30% rise in creatinine upon starting an ARB. Now, we can prove it, of course, by sometimes with a CTA or MRA, but in this case, it's not appropriate because of contrast use in rising creatinine. Sometimes we can do a Doppler ultrasound, but that's very operator dependent. But even if you do these things, sometimes you don't detect the renovascular disease because they are affecting the microvascular disease, and sometimes just appears as kidney size discrepancy in the ultrasound. Now, why do you get acute kidney injury in renovascular disease when you use ACE inhibitors or ARB? Now, when you use ACE or ARB, you end up decreasing the angiotensin II, which then causes vasodilation of the efferent arterioles over here. Now, that's okay as long there's a good efferent supply over here. So the blood will flow quite nicely from the afferent to the efferent, sometimes bypassing the glomerular basement membrane and becoming urine. It's okay as long as the vasodilatory prostaglandins are able to work, but in renovascular disease, this compensation doesn't happen because there is a blockade at the afferent arterioles, leading to reduced blood flow into the glomerulus and hence decompensates. So why did I stop the atenolol? That's again hyperkalemia. Now, many people are not aware beta blockers causes hyperkalemia by pushing the potassium out of the cells. That's exactly the reason why we use salbutamol as a hyperkalemia treatment. Number two, evidence and guidelines. I'm sure my colleagues have already showed you many times of our ESE guidelines, where beta blocker doesn't appear either in first line or second line. And you can consider that in resistant hypertension in certain circumstances. But in terms of pure blood pressure agent, beta blocker doesn't appear in the first few steps. But that doesn't answer why I use the indapamide amlodipine single pill combination. First, reducing proteinuria. Now, in the absence of RAS blockers, we need to identify what's the next best thing to reduce proteinuria, which this lady was clearly suffering from. So there's a study called the Nestor study where there was a comparison between indapamide and enalapril in patients, in diabetic patients who had hypertension and microalbuminuria. And they found, long story short, they found that indapamide-based treatment was equivalent to enalapril-based treatment in reducing microalbuminuria and also blood pressure reduction. That was also confirmed in the advanced study where there was reduction in proteinuria in the arm where patients were taking indapamide. Of course, they also included perindopril, but there was more significant in the patients who were also taking indapamide. Secondly, indapamide and amlodipine combination is kidney safe. Now, there's a large Cochrane review published in 2014 to show that among the thiazide diuretics, indapamide seems to be the most kidney neutral. The rest causes a rise in creatinine. Third, the blood pressure lowering efficacy. Now, after organ protection, then we have to come down to numbers. Now, we know from many trials, many studies like this one, that indapamide and amlodipine combination is much more potent in reducing systolic blood pressure compared to ARB amlodipine combination, for example. Not only this study, but there are large meta-analyses like this one. This is just an example to show indapamide has a very potent systolic blood pressure reduction, second to none, really. If we look at calcium channel blockers, ACEs, and ARBs, the indapamide diuretic came up on top. Finally, the guidelines. Now, we can't use ACE or ARB given the significance of the renal vascular disease here. And hence, the next best thing is to combine a calcium channel blocker and a diuretic, so trying to be compliant with the guidelines too. And preferably in a single pill combination. So she then returns 2 months later. Just to remind you, she's now on glucophage and the medication that I started, which is indapamide and amlodipine combination. So this was April 2019's profile, where her creatinine had returned to baseline along with the eGFR. Her proteinuria had come down. Her potassium, more importantly, has settled, and her blood pressure has reached the ESE target of below 130/80. So moving on to our second case. This is Mrs. Wong. She's 74. She's been a long-standing hypertensive for over 30 years. She's on a telmisartan bisoprolol, and during a routine visit to a general practitioner, her BP was 148/78. The GP started her on amlodipine. Not surprisingly, she developed bilateral ankle edema. She attended my nephrology clinic because she was worried that she had kidney problems, as a neighbor told her that if you have leg swelling, you have kidney problems. But she had a normal renal function and she had no proteinuria. More worryingly, her blood pressure was still suboptimally controlled, and also she still had the ankle edema. So what I did, I stopped the telmisartan and amlodipine. I started her on the single pill combination of indapamide and amlodipine once again. So why did I start the indapamide and amlodipine single pill combination? Reason number one, we were failing to reach blood pressure target despite the combination of amlodipine and the telmisartan earlier with this lady. So what is target? The European Society of Cardiology hypertension guidelines says it's below 140/90, but if tolerated, you can go down to 130/80. Now, the International Society of Hypertension guidelines, which published its guidelines just a few months ago, also says quite the same. Number two, she also has a decreased renin secretion. Why is that? When you're going older, you lose your number of nephrons, and therefore you cannot produce much renin. You also have a tendency to retain sodium when you grow older. That's because your sodium-potassium activity in the tubular cells goes down, and therefore you retain more sodium. And then, as you have hypertension, that will lead to benign nephrosclerosis. Again, will cause you to have low renin amounts in your body. Now, the best drug to, in these kind of patients, there's not much renin for the RAS blockers to work at, and therefore, the best agents for these sort of patients will be a diuretic. As you grow older, you also will have diminished arterial compliance. As you with every decade of your life, you can have thickening, more thickening, and reduced arterial compliance and stiffness, and increased arterial stiffness. Now that leads to reason number 4, which is systolic hypertension, either isolated systolic hypertension or systolic hypertension on its own. Now, why is that? With age, until the age of 50, your blood pressure naturally goes up due to obesity, increasing salt intake, inactivity, adrenergic response, etc., etc. But after the age of 50, the main contributor to rising systolic blood pressure is actually reduced arterial compliance. So during a systolic phase, your arteries are not able to vasodilate as it should do to compensate for the blood pressure. So your systolic blood pressure will continue to rise after the age of 50. But that doesn't happen for diastolic blood pressure, because to maintain your diastolic blood pressure, there should be a certain amount of arterial recoil. Now that recoil doesn't happen after the age of 50, because happens, but in a less amount, because of the arterial stiffness, leading to diastolic dropping while the systolic is rising. Which and in all the landmark clinical trials on the treatment of isolated systolic hypertension, the active treatment group that seemed to work were using either thiazide diuretics or calcium channel blockers. Finally, as Dr. Sri Azari mentioned earlier, we Asians are salt-sensitive people. There's actually quite a lot of evidence for this. For example, in a paper like this, which shows when you salt restrict Asians, there is a greater systolic blood pressure reduction than Caucasians. And not only your race, but as you grow older, you're also more salt-sensitive and female sex. The reason for which I'm not sure, because there doesn't seem to be an explanation. Which Mrs. Wong was. Mrs. Wong was female, she's old, and she was Asian. So she's a very salt-sensitive person who would benefit from indapamide. And because she's old and she has reduced arterial compliance, amlodipine, a vasodilator, may be also quite helpful. Now remember, indapamide also has a vasodilatory effect in addition to its diuretic effect, because it's a strong carbonic anhydrase inhibitor. So Mrs. Wong returns 2 months later in April 2019 after starting indapamide amlodipine combination for over 2 months. She achieves blood pressure target, ankle edema disappears, and she was going back home quite happy. But I also decided I'm going to stop a beta blocker because it seems that the blood pressure was under reasonable control. And I was quite interested to see what happens. So when I brought her back 2 months later, before I discharged her back to the GP, her blood pressure was still within target. So she went home with just one blood pressure medication at the end, or one pill rather. So I thank you for listening, and back to the panel.
Thank you, Dr. Wijaya, for your informative talk. I think after we listened to your talk, actually, I think some of my colleagues who practice in primary care, they know that these elderly patients who are salt sensitive, and then with the CKD patient, they benefited from this indapamide. So perhaps you can share with us what is your experience when you want to change, or when you want to start the indapamide, and how you do it. If let's say those patients already on hydrochlorothiazide, if let's say you want to change to indapamide, any precautions that you are going to take?
Well, if they're already on hydrochlorothiazide and they are biochemically been fine and they don't have any problems, it's absolutely safe to switch them to indapamide. Of course, with changing any medication, you need to make sure that they are okay with the new medication, but there shouldn't be a problem because both thiazide diuretics, indapamide, so you just watch out for additional blood pressure drop. But yeah, no problem. You can switch them to from hydrochlorothiazide to indapamide. But before you start indapamide, you should actually check their vitamin profile just to make sure you don't have hypokalemia.
Is it possible you repeat the line unstable?
The last part of your comment. I think there was a dropped signal. What was the comment? The last comment of the video, we didn't hear that.
Yeah, last comment was, if you're going to be starting indapamide, it's better to check a renal profile and make sure your potassium sodium is all right.
Okay, thank you. I have a question perhaps and a comment as well. You mentioned the blood pressure failure to be controlled with your ARB, which is telmisartan at the time. I know not many people are aware of this, but the maximum dose of telmisartan is actually 160 milligrams. Now, I rarely use that dose myself. Usually, we use 40 and 80, and many combinations are with 80 milligrams and 10 and 5 and so on and so forth. But if you look at the literature, there is also a dosage with a maximum dose of 160 milligrams, and I think not many people have considered that in some of their management. Maybe it's worth just mentioning that. So my other question is, of course, and this is to the panel, not just you. Given the fact that there is, of course, good evidence for RAS blockers, even though renin may be low, for reducing cardiovascular disease. Would you be compelled at any time to start these patients on ACE or ARB once perhaps the potassium is better controlled? Comments from perhaps the cardiologist Krish and Wood first. Are you concerned that you should be putting them before you pass it over back to Dr. Vijay about try and squeezing in an RAS blocker in this patient for cardiovascular benefits, perhaps?
Well, I think with the history of worsening kidney profile with ARB and S, are all very cautious to restart the patient with this group of antihypertensive. Probably once the renal profile has gone back to normal, I will pre-screen whether this patient has any renal vascular disease before I would seriously consider to restart the S. But of course, I will ask the opinion from nephrologist whether it's time to restart. Because I think will be high chance that the patient will likely go back to hyperkalemia or renal impairment.
Where's your comment?
I think from my point of view, I will definitely want to rule out whether there's evidence of renal artery stenosis or renal vascular disease first, because if you look at the incremental of the creatinine, it was drastic change from more than 30% once he started a RAS blocker. So why is it so? Is it because of renal vascular disease? As I think Dr. Vijay has rightly put it, ultrasound Doppler and also ultrasound KB is operator dependent. If it's possible to do a CT, then that'd be good once the baseline is normal. But I think I will definitely co-manage this patient with a nephrologist first before I start my RAS blocker.
Before I pass it on to Dr. Vijay, I wanted to comment on an observation. For the kidney function, for the change in EGFR, this patient, the first patient, exhibited quite dramatic changes in hyperkalemia. We don't often see that. I mean, at least from the cardiologist point of view, we see EGFR of 59, but potassium don't usually go up that much, or even if they drop lower, but the potassium don't climb up that much. Sorry. So, I mean, what is the possible explanation you think in your patient where the potassium goes up, perhaps out of sync with the EGFR value, or is it something that happens often in nephrology?
You asking me the three?
Yeah. The potassium, the change in potassium, the dysynchrony with the mismatch between the potassium and the EGFR.
Absolutely. We get plenty of calls from ED saying that these patients should be admitted to nephrology because they got hyperkalemia with a creatinine of 200, and I'll just tell them to call back the cardiologist, and I can co-manage the hyperkalemia with them, because the hyperkalemia doesn't really kick in until you're unable to produce urine. So there are other reasons for hyperkalemia. In this case, the hyperkalemia was most likely due to the hypoaldosteronism brought on by the RAS blocker.
Right. Okay, any first question back to you?
Yeah. Okay. One question from the floor. in patients with hypertension and proteinuria and already on full dose of ARB and full dose of amlodipine, any role of adding thiazide?
I see this plenty of times. They are adding diltiazem to amlodipine. Number one, there's no evidence, and number two, I wouldn't do it. Adding another calcium channel blocker to a already existing calcium channel blocker, although one is another non-diuretic. What I would do is I would, if you're really concerned about the diuretic, there are a few things we can do. Number one is consider, if it's purely a hypertensive patient, consider indapamide for proteinuria reduction. If you happen to have diabetes and not so far in the future, even if you're not diabetic, you can use SGLT2 inhibitors.
Yeah, this is another potent drug.
And also SGLT2 inhibitors can reduce about 5 millimeter mercury of systolic blood pressure.
Yep. Okay. So, yeah. Dato', you want to say anything?
No, just get to. I think you want. I want one question. That sometimes I see my distinguished nephrology colleagues stopping SGLT2 because the kidney function has deteriorated, and that was a common issue. I have used many patients SGLT2 for their cardiovascular benefits, even in patients with very, very bad renal disease, and it's not purely because for the glucose lowering effect itself, but for the SGLT2 receptor effect, which is probably distributed in the cardiovascular areas as well. So, what is your view about that? So that maybe I can familiarize myself with the thinking of that why it stopped.
Right. In terms of SGLT2 and EGFR, it's nothing to do with safety. It's all to do with the licensing of glucose lowering, because these drugs were designed to be glucose lowering drugs before. So when they realized, because they work with the tubules, they don't produce much HbA1c reduction. In fact, when your EGFR is 30, your HbA1c reduction is about 0.1 to 0.3. Therefore, they didn't license these drugs when the EGFR goes down, because it's not going to produce the glucose benefits. But actually, we have realized in the last 5 years or so, they have so much extra glucose benefits, heart failure, kidneys, etc. So they're extending the horizons, because these things happen whether or not your EGFR is bad. In fact, you can see the DAPA CKD trial extended the EGFR to 25, and the currently running kidney trial is EGFR 20. And so far, what I heard, they all are producing, good effects. Whilst they don't reduce glucose, like you said, Dato', it's for other protection, your heart failure protection and all that. In the past, I would have had a low threshold to stop it, but now I just leave it if the EGFR drops, because they're not good.
All right, welcome to the club. Welcome to the club. All right, Cheng, another question.
Yeah, I think because due to the interest of time, I think we need to stop and move to the next talk. Thank you very much, Dr. Wijaya, for your wonderful sharing. Let me just introduce the next speaker, Dr. Tan Lee Ping, who is a consultant nephrologist and physician at Ara Damansara Medical Center, Ramses Sime Darby Hospital. Is actively involved in CME and public education. Tonight he's going to present 2 case studies on hypertension management among patients with CKD. Dr. Chan, the screen is yours. You need to unmute. Dr. Tan, you need to unmute.
There we go. Can you hear me?
Yes.
Yes.
Okay. Let's see. Show screen. Hang on. Okay. So I'm fortunate to present last, and that means all the difficult questions are done. So I'm going to do a very brief sort of case sharing, and we'll concentrate on just diuretics, I think, because I think when we wrap up here, you've seen that the theme of today has a lot of to do with diuretics and salt sensitivity, etc. So let me share just a few cases to illustrate some minor details upon how a nephrologist or me and Vijay would look at blood pressure from the context of how a diuretic would work and where a diuretic could benefit. So here are my disclosures and the disclaimer. So I'm going to begin by sharing with you the first case. So this particular one is illustrating how we think about using a DCT diuretic. So a 69-year-old gentleman is referred for high blood pressure and renal management. He has got underlying history of high cholesterol, he's got a stroke, he has hypertension, he's got ischemic heart disease. He's on a combination therapy of enalapril, and I noted he's taking half tablet of this combination, 10-10 dosing.
Thank you. Sure.
He's also on atorvastatin 40 and fenofibrate 200 milligrams. He's on clopidogrel, he's on gabapentin, he's on colchicine as needed. And his blood pressure when he came in is about 148 on 65. His heart rate is about 90 beats a minute. His home blood pressure, which I like to get our patients to do as well, is ranging more or less the same, about 140 to 150 millimeter mercury systolic. So in general, he's a gentleman with uncontrolled hypertension with underlying cardiovascular risk. You would even say high cardiovascular risk, and our job is to define what are his issues. So nephrologists like blood tests, and I'm certainly no exception. So here are his blood tests, and they help me guide what sort of medication I should give. So here are his laboratory information. His sodium is 143, his potassium is 5.1, his chloride is 113, his urea is 9.7, his creatinine is 210, his bicarb is 18. Now, if you can't get a bicarb, you can actually get the lab to give you a total dissolved carbon dioxide, which is actually fairly easy to do, and they usually do that on a regular Buse sample. Or you can ask for venous blood gas, which is a point of care test, and that should be able to give you a estimated bicarb, which is probably fairly acceptable. And if we are dealing with, in particular with renal patients, the bicarb is a one variable that is fairly useful and very important to have, especially when we think about blood pressure control. Uric acid is 0.58. Looking at the lipid profiles as follows: his total cholesterol is not elevated, 3.9, unusually low. Triglycerides 2.7, LDL is good, 2.3, HDL 0.35, cholesterol HDL ratio 11, HSCR 2.5, and his urine analysis has no protein. So what are his issues? So I think if you were to look at his issues in a gentleman like this, which is fairly box standard sort of kidney patient, which you would see in your own clinics, or they would appear in the GP clinic, or they would appear in the cardiology clinic, or in the neurology clinic, or in the renal clinics, or in general medicine, family medicine clinics. I think our issues remain the same, and these are the general issues, or the regular issues that most people would define. The first would be how to risk reduce his cerebrovascular risk, his cardiovascular risk, and by way of that, how to manage his blood pressure. And of course, speakers before me have already talked about optimum targets and some thoughts about best agents to use depending upon the underlying risk and the optimum targets they are attempting to achieve. Because I'm a nephrologist, part of my job is also to think about the patient's kidney function, and the issue here is also going to be the kidney function and how to best optimize it and how best to deal with it. The third is something that is rarely thought of, which is potassium levels and acidosis, and that's, I think, a very dear topic to those who think about multi-kidney disease patients all the time. is how to manage or how to predict or how to control possible fluctuations in potassium, and how to manage and how to control whether or not there's any link between potassium and acid-base balances, and how they interplay into how a patient's blood pressure would be well managed or not well managed moving forward. And of course, lastly, the issue is hyperuricemia. Now, we won't touch on all of these issues. I'm going to limit my talk to just the blood pressure itself, and thinking about specifically about how diuretics can help in this particular time point. So yeah, we agree that we are going to try to treat the blood pressure to a goal of which 140 over 90 millimeter mercury is at a minimum goal that we have. And of course, because of his renal impairment, which is implied target organ damage, we would like to aim for a slightly more tighter goal if possible. So if you control his blood pressure down to 130 over 80, there's thought to be some additional benefit. There is a caution to trying to treat him to too low, down to a normal 120 over 80, because in certain patients, in particular, if they have diabetes, there is a possibility that there's impaired renal autoregulation. Actually, we can do more harm than good when it comes to renal outcomes. So how do we do it? I mean, there are a couple of options if we stop and think about a patient like this with renal impairment and with cardiovascular disease. So who is on the medication she's on? So we could add a diuretic. We could, and there are good arguments for all of these. We could add a diuretic. We could discontinue an ACE inhibitor and substitute it with a diuretic or calcium channel blocker. We could add a beta blocker and continue with a perindopril and amlodipine combination. We could increase the perindopril amlodipine combination to a tablet a day. We could add a non-first-line sort of blood pressure agent, which doesn't interfere with anything, which is a alpha agonist like prazosin and moxonidine, and continue our current perindopril and amlodipine. Or we can add a vasodilator and continue our perindopril and amlodipine. So all these choices have, we've seen variants of all these choices appear in clinics, myself, my colleagues, and you as well. And certainly all these choices have been attempted in patients who are presenting one way or the other at any one time. And is there a right answer? Is there a best answer? So if we to go through each of these, I'm going to tell you that my particular option is to add a diuretic. And there are fairly good reasons for that, I think. But let me just go through the rest of these options and discuss with you why they are certainly some reasons behind why you would not do B, C, D, E, or F. So let me just deal with the easy ones, which is the E and F. So in E and F, you're adding a second-line antihypertensive. They're easy. Prazosin can easily be ramped up to very high doses, up to 15 to 20 milligrams a day. The blood pressure responds to them remarkably well. So is moxonidine, which is a once-a-day, 24-hour alpha agonist. They control blood pressure wonderfully. Unfortunately, there's no clinical trial that actually illustrates that patients on these sorts of agents actually attain cardiovascular or cerebrovascular or renal benefits. So we will be controlling blood pressure without the added benefits that the other main categorical blood pressure agents could give us. And it's the same with adding a vasodilator. So adding an additional vasodilator like minoxidil certainly can add additional blood pressure lowering benefit to your perindopril and amlodipine combination. But again, there's no clinical trials that illustrate that there's any beneficial effect beyond just pure blood pressure lowering that might benefit this particular patient with renal disease and high cardiovascular risk. What about increasing perindopril and amlodipine dose to 1 tab a day? Certainly you could do that. You could, if he's not on an optimal dosing of perindopril and amlodipine, you could certainly increase that from half a tablet a day to 1 tablet a day, trying to aim for an optimal blood pressure goal. But I'll show you why I think that is a troublesome method, because I think it will bring in more problems, and we'll talk about that. You could add a beta blocker, and again, I'll You can do that. It will control the blood pressure, as will an increase in parenteral amlodipine to 1 tablet a day. Again, I think it will attract a little bit more issues. You'll have fewer downstream, and I don't think it's the optimal way to treat this patient's blood pressure at this present time. What about stopping his ACE inhibitor altogether? What about seeing that this patient who comes in with renal impairment, would you make an argument that maybe the ACE inhibitor may be doing more harm than it's good, and change this patient to a calcium channel blocker diuretic, and then up the doses of these two and see whether or not the blood pressure could be controlled? So there are arguments to doing this particular method, actually. There are cases that actually have illustrated and certainly clinical studies that have been presented to suggest benefits to removing the RAS blockers. Now, at the same time, there's conflicting and equipoise with this, because in patients recently published who were off ACE inhibitors, although the renal impairment got better, the cardiovascular outcomes got worse. So as much as possible, I think we try and keep the ACE or the RAS blockers where they are. So that leaves us with the one option A, which is add a diuretic. So is that the best option? So let's look back at this particular case. So if you look at this particular case, you see that what I chose to do was to add a diuretic, in this case indapamide, which is a distal convoluted tubal diuretic. And of course, the blood pressure comes down as it would with most of these other options. So in most of these other options, blood pressure lowering is not the argument. The argument is whether you can achieve blood pressure lowering with the benefit of all the other plus benefits with the minimum of side effects to your particular patient. And here's the thing that I want to point out. When you look at the laboratory information, these are the benefits that actually have accrued to the patient as a result of adding a diuretic. And the figures that I quote out are the figures that I want you to pay attention to. In particular, I want you to pay attention to the potassium. So the potassium with the addition of the diuretic went from a borderline 5.1, and in most labs, the upper limit of normal is somewhere between 5.2 and 5.4. And later on, I'll show you how important potassium is as a covariate in the treatment of high blood pressure. So in most cases, you can add blood pressure agents which can modify potassium control, like ACE inhibitors or ARBs or diuretics, and not suffer any real effects from it, because your kidney, if they're working well, it's gonna alter potassium excretion or secretion, and you'll be able to maintain your potassium in an optimal range. However, if you have a patient with any other factor on board, for example, the patient is using traditional medicine, the patient is using NSAIDs, the patient is dehydrated, prone to dehydration, the patient is on an ACE or ARB or anything else which can interrupt the kidney's ability to control potassium equilibrium, then you get trouble with hypo or hyperkalemia. And in patients with high cardiovascular risk, hyperkalemia and hypokalemia is one thing that you really want to avoid, because there's a J-curve sort of picture when it comes to potassium levels in the body. If it exceeds a certain level, the mortality rate tends to go up. And if it reduces below a certain level, the mortality rate tends to go up. So in this particular case, then, we anticipate that if I were to use adding a beta blocker or increasing the parenteral amlodipine dose to a tablet a day, what I'm going to see is that borderline potassium of 5.1, which if you look at the blood test report, actually is not bold, is actually within the normal range, and therefore usually escapes notice, will invariably, possibly, quite probably in the next time round, when you see this patient again, have increased to beyond a normal laboratory range. And that's the one thing that you want to try to minimize, because one of the things that renal patients and cardiovascular patients die from is sudden cardiac death. And one of the possibilities behind the sudden cardiac death is possibly the irregularities in potassium that actually can result from medications or whatnot. So a DCT diuretic here is actually an optimum choice. During the physical exam, it's unremarkable, and later on I'll show you a contrasting case to bring out a different sort of feel into using a diuretic. But in this particular case, is primarily to show that potassium actually is a huge choice behind why we choose diuretic as an optimum add-on to an antihypertensive. So let's look at a second diuretic case to illustrate how diuretic could be used. So this is a 50-year-old lady. She's referred for uncontrolled hypertension. She's got an underlying history of diabetes on insulin. Let me go back to the prior case. So in this particular case, one thing I forgot to mention is that one of the benefits of checking a bicarb is you get a sense of the acidosis level of the patient and how hyperkalemic-ish or hyperkalemic-genic these patients are. In this particular patient, there's probably an element of renal tubular acidosis that would actually reflect an inability of the kidney to dispose of potassium correctly, and therefore, would increase the risk of hyperkalemia. So the same thing can be seen here. Although in this particular patient, I chose to illustrate a potassium that is within the normal range. So this is a 50-year-old lady with history of diabetes controlled on insulin. Latest A1C is 7.2, blood pressure is 150/90, heart rate is 68 beats per minute. On examination, now this patient is a little bit different. She's got bilateral 1+ edema up to maybe the thighs. She also has abdominal wall edema. When you press in, you can see some pitting that remains. She is on perinapryl 5 milligrams a day. She's on amlodipine 5 milligrams a day, and nevidolol 5 milligrams a day. So when you look at her laboratory information here, the sodium is 130, the potassium is 4.2, chloride is 110, urea is 11, creatinine is 180, bicarbonate is 19, uric acid is 0.48, which is borderline high. Urine analysis shows 4+ protein, 1+ heme, and 5 red cells per high power field. So how do we think about this patient, and what sort of issues are now present in this particular patient, and how does this patient differ from the case that we see in diuretic patient 1? So how do we proceed? So here are the things that actually would require us to consider this patient slightly differently from the other. So in this particular patient, she definitely has got 4+ protein, and this could be consistent with a nephrotic range proteinuria, possibly related to an underlying diabetic nephropathy, which is fairly common. Up to 30 to 50% of patients on diabetes eventually have some semblance of proteinuria. This patient is obviously extravascularly volume overloaded. So this patient has got signs of volume overload that can be evident in the presence of edema and abdominal wall and edema in the lower extremities. This patient is also on a medication which increases the likelihood of edema occurring, especially if noticed in the lower extremities, and that's using a calcium channel blocker, which increases permeability in the blood vessels. And you can also tell that there's increased water in the intravascular space by looking at the sodium content. The sodium content is low, 130, that's hyponatremia. So this patient would have hypervolemic hyponatremia in context of diabetic-related kidney disease with nephrotic range proteinuria, possibly nephrotic syndrome, accentuated or aggravated by the presence of a calcium channel blocker, which may increase vascular permeability. So in this particular case, both you and I would say that this particular patient, the blood pressure might very well be mediated by the presence of excessive fluid. So if you're going to treat blood pressure in this particular patient and therefore improve possibly renal perfusion, you would want to fix the volume overload. And how would you do that? You would do it by a diuretic. And if you're going to use a diuretic in this particular case, and if you contrast this particular case with the prior case, you would see that the diuretic choice that you would use would be different. No longer are you using a DCT diuretic or thiazide-like diuretic like indapamide, because the indapamide or the thiazide diuretic does not have a strong celluretic potency. It does not allow the excretion of sodium to the extent that you can result in a significant volume loss. That's number one. Number two, it cannot be ramped or dialed up as per necessary. If you use indapamide or a DCT or thiazide-like diuretic, you start at a 1.5 milligram dose, and that's it. It's a fire and forget kind of a dosing. With a loop diuretic, that allows you to increase that cellular ureasis, increases sodium excretion from the kidney, and you can ramp it up as per necessary to remove salt from the total body space, the total body water, and increase as necessary to achieve enough volume excretion such that the patient becomes euvolemic. And only when they are euvolemic and without the presence of excess salt in the body circulation can we then begin to see what is the underlying blood pressure and whether or not that blood pressure needs to be addressed by different ways. So the case for diuretics has always been the presence of salt. And in just a few slides, I'm going to share with you that blood pressure, as we know it, has got multiple regulatory pathways. It is governed by the RAS system, by sympathetic nervous system, and by total body sodium. Different patients have different expressions of these pathways in their phenotype of blood pressure. If you dedicate yourself to just looking at salt, you find that, as my other esteemed colleagues have talked about before, that our Asians are a salt sensitive and indeed a salt intake, a high salt intake population. Certainly, if you look at this particular paper showing salt intake, you find, and no surprise to you, that the salt intake in Asians, as seen in the Chinese population here, is fairly high, far above that which is recommended. Sorry, this is just a slide showing the importance of potassium modulation. So how does sodium chloride in particular affect the blood pressure? So it turns out it's not just a volume relationship. It turns out that the presence of salt within the circulation actually is transmitted to the brain, and what it actually does is resets the brain with and the baroreflex mechanisms that extend from the brain and into the blood vessels, and they control a steady state blood pressure level, and they modify this steady state blood pressure level by way of augmenting arterial myocyte calcium signaling, as illustrated in this very elegant graph by published in the American Journal of Physiology back in 2012. So the increase in vascular sodium results in a transmission of sodium content to the CSF, and that actually alters brain patterns, and that modifies tone within the blood vessels, therefore giving us a very strong physiological reasoning behind why we should actually modify salt, why we should actually control salt in patients with high blood pressure. So just to be a nephron about this, so there are a couple of diuretics that we can use. So the loop diuretic, as evidenced here, which blocks the sodium potassium 2 chloride in the thick ascending loop of Henle, are actually great for volume control. So if you have a patient who you're suspecting has volume overload, you wouldn't use a thiazide diuretic. It's not powerful enough. It doesn't cause enough sodium loss. You would want to use a loop diuretic to achieve euvolemia. If you're thinking more blood pressure, you're thinking more thiazide or thiazide-like diuretic. And if you're thinking aldo, then you're thinking the mineralocorticoid receptor blockers like spironolactone. So why is the renal patient more salt sensitive? There are numerous reasons, but it can be said that the renal patient has got an accentuation of their genomic RAS activity within the cells, leading to an increased mineralocorticoid receptor upregulation and therefore blood pressure elevation. So in summary, I think I just wanted to share that when we think about patients with blood pressure, especially the renal patient, which are more salt sensitive and they are more prone to getting all sorts of issues, that we don't forget a couple of issues. Number one, diuretic.
We can't hear you. There must be something wrong with the audio.
Or internet.
Is it the bandwidth?
Zatan, can you hear us?
Your transmission has frozen. Are you okay? Oh, he's in a summary slide. While we're waiting for him to get online again, maybe you can address some of the questions, Prof. Chen?
Okay, one of the questions they ask, how common is the Cont syndrome? As we know that sometimes we thought that hypokalemia is due to the diuretics, but could be due to the secondary cause of hypertension. So maybe Dr. Wijaya, would you like to comment on this?
The question is how frequent, how common is Conn syndrome?
Yep. Yep.
Actually, Conn syndrome is very. I've only seen probably one case in my career. It's quite rare, really.
I mean, it's not. It is one of the contributors of secondary hypertension, and one of the rarer ones who contribute to hypertension. Conn syndrome, I suppose, is the more expected one. I mean, the figures have said about 10% of resistant hypertension are actually because of undiagnosed Conn syndrome. But as Dr. Vijay has mentioned, it's not a very common thing. We've hardly seen it, but we should suspect it at the back of our mind once you have resistant hypertension and those with that and hypokalemia. It's a good idea to check it and then check the renin levels. Not always easy in our patients, and there's also a cost issue. But I think it is an important contributor to hypertension. Dr. Tan is back with us. Sorry, we lost you earlier.
Yeah.
Okay. So, all right, no problem. Thank you very much for your presentation. It was very nice, very elegantly laid out the various diuretics and the important. I think you made the point that diuretics are the mainstay of therapy for hypertension, especially now when in Asia the use of single drugs are a moot point, really, because many people are on combination therapy. Eventually, one of them will be a diuretic. You start out with combination therapy as recommended in the guidelines, RAS blocker if indicated, and a CCB, and then subsequently move on to a diuretic, which makes sense. Do you have any final comments since we lost you early on there?
No, I think thankfully I got lost when the last slide was on.
Yeah, Dr. Tan, can ask you about this question from the floor. In primary care setting, when we use this diuretic, it's very common to encounter hyperuricemia following this drug. So I think some of us may use furosemide instead of diuretic because of this hyperuricemia. So what is your comment and for your expert opinion on this?
Yeah, I think that's a fun question. So it brings about a couple of things. I mean, number one is whether or not hyperuricemia actually means anything. If you get iatrogenic or idiopathic hyperuricemia that actually does not translate into gout or does not translate into complications as a result of that uric acid. For example, you don't get uric acid stones, you don't get uric nephropathy. Then the question is whether that hyperuricemia actually means anything when it's actually triggered or made increased by something like a diuretic. There are certainly studies out there that suggest that the presence of uric acid levels, if you link them together with renal dysfunction, actually treating uric acid levels result in an improvement in renal impairment. However, the question is whether those uric acid levels are actually increased and are actually causative for the renal disease, as opposed to in what you mentioned, whereby a diuretic actually triggered an increase in uric acid because of maybe some subclinical volume depletion, as an example. So generally, I don't really pay attention much to uric acid levels, even if they're increased in diuretics like indapamide or diuretics like hydrochlorothiazide for that particular reason. The second thing is that actually, if you look at studies and you look at loop diuretics versus thiazide or thiazide-like diuretics, like for example the ALLHAT trial, which is what is fairly well quoted. I mean, if you use clothalidone, there's actually very good evidence behind cardioprotective outcomes. But there's no such cardioprotective outcomes comparing loop diuretics in blood pressure management. So if we're using a loop diuretic to achieve cardiovascular endpoint outcomes, then there's no basis for us to do it if we're comparing a loop diuretic versus a thiazide or thiazide-like diuretic. So I think if we're gonna ask the question, okay, which of these diuretics actually is most linked to beneficial cardiac outcomes, we'd have to say it's got to be a thiazide or thiazide-like diuretic. And for the loop diuretic in particular, its role, I think, lies in its benefit in volume reduction. The minute you can get volume reduction, the minute they achieve euvolemia, then the question is, do you want to take them off? Can they go off? Do you want to switch them or swap them to to a thiazide or thiazide-like diuretic? I mean, I think that's the question that sometimes comes up, which I don't know how to answer.
Thank you. In the past, I think they try to link with uric acid and the cardiovascular outcome. I'm not sure whether now still is part of the practice as one of the target to achieve. Maybe we ask the other panelists, or Dato, you want to give any comment?
Yeah, I mean, there were papers in the past linking uric acid levels with in heart failure and outcomes, but I think you have to take things into perspective. And I think for hypertension, I tend not to be fixated on uric acid levels, but rather looking at cardiovascular risk first. And cardiovascular risk together with hypertension targets are still the most important top two targets I would aim for. There are such a thing as, to me, in my personal view, surrogate markers such as, of course, things like uric acid, the level of proteinuria, which are, and of course, kidney function, which are also important nonetheless, and indirectly related to cardiovascular risk outcomes. But I think your choice of medication, and this is where it's important in hypertension medication, the choice of hypertension medication must impact on these two things at the end of the day. The first is, of course, given all things equal, cardiovascular risk reduction, and to me, hypertension, trying to achieve that target. I mean, if the uric acid goes up a little bit, it doesn't really translate into much clinical significance as far as we are concerned. And you can manage if it does go up with reduction, adjustment of doses of the thiazide diuretics. And we know that the uric acid levels goes up incrementally over time, over 3 to 4 years of usage of thiazide diuretics. And even then, in some individuals, and usually there is no cost to change. If you change it, as Dr. Tan has rightly mentioned, to change to a loop diuretic, which is a cardio-neutral drug, then you're losing out on major. And we know that a couple of microalbuminuria separate out very, very early on, within weeks of blood pressure reduction, whatever quantum the blood pressure reduction is. So try and get that blood pressure reduction with the right drugs to reduce the risk. At the end of the day, if all diabetics or renal patients die of cardiovascular events, so that's what we want to try and mitigate. Any comments? I mean, from anyone else, please throw in your views. You're muted. You're muted.
Thanks, Dato. I fully agree with Dato. I think at the end of the day, what we want to achieve to make sure that patients achieve the targeted BP. Secondly, try to minimize the target organ damage as much as possible, especially the CV reduction, cardiovascular risk reduction. So, of course, if you use the loop diuretics and all that, you have a hyperuricemia. But as Dr. Tan has rightly put in, as long patient has no symptoms, it's just hyperuricemia, doesn't develop complication, I think we can monitor first. Even at all, they do have symptoms, that I think we can manage that as well.
There's another question on benedipine and clonidipine. Benedipine is a DHP like amlodipine, and it's been around for some years. I'm not sure it's available in Malaysia, but it's in Japan and the Far East. Also, clonidipine, also a calcium channel blocker. The question is, are they more effective in countering proteinuria as compared to amlodipine? There was a paper in 2010, apparently, that was done in Japan, comparing benedipine, which is another type similar to amlodipine, which showed it was better in lowering proteinuria. But I mean, I've not used benedipine and clonidipine myself, and I don't think it really is as significant in trying to reduce the level of critical proteinuria that we're trying to achieve. We can get better reduction with the other agents, including the ARBs. Any comments from anyone else about these two drugs?
We don't have benedipine or clonidipine, but we have the carnitine, which is one of the new generation calcium channel blockers, and those seem to give us maybe slightly better proteinuria improvements compared to AMLO. But these are small improvements, I think.
Yeah, and less edema apparently with xanthine or lenaclidipine.
Yeah, that's right.
So, Prof. Cheng, maybe we can both give some final comments. It's time to end the session. As I mentioned earlier on, the hours will fly by. If you have questions and issues, there doesn't seem to be any questions, is there? Dr. Tan, the neurologist, has had to leave us because apparently there's somebody who's had a stroke. But that's probably the last question about benadryl and clonidipine. I personally, before I pass it on to Prof. Chen, I'd like to thank all of you, the distinguished speakers, the panelists, and of course, Prof. Chang, my colleague, and all of you have been kind enough to tune into this webinar. I hope you learned a thing or two, as we have learned from you, and that we should continue to try. This is the state of things that will be here for some time. We have this transmissions, vaccine though it may be, but I hope that we'll have better days ahead. But certainly, COVID or no COVID, you must make sure the blood pressure of your patients are well controlled. And with that, final comments from Prof. Cheng, I'd like to thank all of you and Servia for hosting this event.
Yeah, thank you, Dato. Actually, I also would like to thanks to all the fantastic speakers for the wonderful talks. I think until now we still have around 270 participants until just now from 300. Really, it's a very good response, and I think the talk is fantastic. Thank you very much. I think we need to close the session now, and please join me to thanks to all the speakers and the